Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We are going to have a very informative conversation about a very important topic. And without further ado, I will turn it over to our founder, Dr. Randall Maxey.
Good afternoon, everyone. Like Dr. Navy Stevens, we're quite flabbergasted that we have somebody who's a superstar in the world of medicine, and we're going to talk about a topic that is very important to our community. Dr. Marietta Borum is a gastroenterologist. What is that? She specializes in diseases of the digestive system and the liver. And guess what? Not only is she an MD, a medical doctor, but she is also a doctor of education in ED. She has a master of public health. She's a master of the American College of Physicians. She's a fellow of the American College of Gastroenterology. And she is one of the few nationwide chairs of a major department at a major medical school, George Washington in Washington, D.C. And we're very honored, Dr. That you would join us today. And we'd love you to educate us as much as you can about colon cancer and any other topic that crosses your mind. Thank you so much for being. She's also chair of gastroenterology for the internal medicine section at the NMA. Am I correct?
I am, yes, indeed.
Oh, good. So please join us and listen to Dr. Marietta Borum.
Thank you so much, Dr. Maxey. I really appreciate your invitation and very generous introduction. I am happy to be here, particularly, as we all know, to talk about one of the topics that I have done a lot of writing and research in. And it is so pertinent because colon cancer is, in fact, something that impacts not only people globally here in the United States, but certainly has a significant impact upon Blacks in the U.S. And so, what I would like to do, if possible, is to share my screen um, because I'd like to just show a few slides about a topic related to colon cancer screening in particular. And so, one of the things that I want to focus on today was how to lower our risks for colon cancer and to do it with early detection, doing some protective activities that we have and emphasize on screening because there have been some advances in that area. And again, I think it's terrific that we're looking at this particular topic because March is, in fact, Colon Cancer Awareness Month. We all know that colon cancer is one of the most common cancers worldwide. It's the third most common cancer in men. It's the second most common cancer in women. And it's the fourth most common cancer death. The highest incidence rates are in North America, in Europe, Australia, and New Zealand. The lowest incidence rates are in parts of Africa and South Central Asia. But as we all know, data is collected differently around the world, and sometimes we are not collecting data the same way we're doing here or have been in the past. And so making comparisons between countries is not always easy to do. But with what we know now, we know that our lowest rates are potentially in parts of Africa and South Central Asia. But nevertheless, the US is one area that is particularly affected. The estimates for colon cancer in the US, based on the American Cancer Society, there's about 154,000 new cases annually. 107,000 approximately are from colon cancer, with about 47,000 being from rectal cancer. And there's about 53,000 deaths each year in this nation. In the United States, there are also regional differences. The lowest rates in the US are in Utah, in Arizona, New Mexico, and in Colorado. And our highest rates are in Mississippi, Louisiana, Arkansas, and Kentucky. And when you look at the range, we see in Mississippi there's about 46.7 per 100,000 people affected, versus Utah about 28.5 per 100,000. And there are multiple factors that likely contribute to the geographic variances, including environmental exposures, lifestyle practices, and cancer rates and screening rates. So in the United States, when they say that developing colon cancer, you have about a 4% risk, that works out to be about 1 in 24 men and 1 in 26 women. Sorry. The incidence is much higher in men than in women across the board, no matter which ethnicity you're looking at. African Americans have a higher rate of colon cancer than whites. And if you look at the chart on the right, you see that Black men in this nation have the highest rate of colon cancer. Black women have the highest rate when you compare to other ethnicities. And of course, colon cancer is higher in patients with specific inherited disorders. So the risk for colon cancer begins to increase about age 40, and then continues to increase, significantly increases at ages 50, and then it doubles with each subsequent decade. When you look at the SEER database and other registries, we see that the colon cancer rates are increasing under the age of 50 and actually decreasing in older age groups. So some of the epidemiologic data that came out of NCI show that there were a decrease in our death rates. But when you tease out the information, you find that while it's decreasing across the board, it was actually increasing at younger ages. So the risk factors for early onset are really multifactorial. And there is currently no evidence that early onset colon cancer is clinically or genetically distinguishable from average risk onset colon cancer. So the cancers that are happening in young people look just like younger adults, look just like cancers that are happening in older adults. And then you also find that those cancers, because they often present at a younger age and people aren't in tune for getting screened because they're not of age to getting screened, very often our younger adults are getting diagnosed with much more advanced disease. And so colon cancer disproportionately affects Blacks, like we mentioned before, and this looks at our death rates. You can see with the red dot aligned, those are Blacks in this nation, compared to the green line, which is all races, and whites, which are in a yellow line that may not be as clear because it overlaps with the green line. You can see that about 20% Blacks are 20% more likely to get colorectal cancer and 40% more likely to die from colon cancer. And I just showed a couple of these pictures because some of the high-profile Black Americans affected by colon cancer have begun to heighten our awareness. And as I go through some of these pictures with the next couple of slides, you can see that many people were quite young. You can see that Quentin Oliver Lee was only 34, Chadwick Boseman was only 43, Natalie Desselle Reid was only 53. And if that's when they were diagnosed with metastatic cancer, you can assume that that cancer started with those precancerous polyps about 10 years prior. We also have some other distinguished Americans who died from colon cancer most recently, and we have some athletes who suffered from the same issue. So as I talk to my patients and as I go out and talk to people about getting screening, I try to bring up people that they may know because sometimes this isn't something that's well talked about within our communities, within our families. And the mean age of colorectal cancer is much younger than in the general population. Black Americans are more likely than others to be diagnosed with colon cancer under the age of 50 and more likely than others to die under the age of 50. So the vast majority of cancers, more than 95%, develop from colon polyps. So we see a normal colon, we see a precancerous polyp that can be easily removed, and that precancerous polyp, if it stays in too long and gets big, becomes colon cancer, which is much more difficult to address endoscopically. And there are, in fact, as we all know, non-modifiable risks. There are specific risks that increase our chances of getting colon cancer. We know that 90% of cases will occur after age 50, but with the increasing number of people getting diagnosed earlier, our screening now starts at age 45 across the board. We know that men have higher rates than women. While it affects both genders significantly, men have a higher incidence and a higher death rate. African Americans or Black Americans in this nation have among the highest rates of mortality, but there are also increased rates in Alaska Natives, some Native Americans, and some Ashkenazi Jews. So while we have the highest rate, we also have significant rates in some pockets of our population. There's also personal histories that we must always remember. Inflammatory bowel disease significantly increases our rate of colon cancer. Ulcerative colitis more than Crohn's. When Crohn's increases our rate of colon cancer, it's because there's been colonic involvement, and usually more than a third of the colon involved in Crohn's disease. And ulcerative colitis has a higher rate, and we have extrapolated our risk in Crohn's disease based on our UC knowledge. And people with adenomatous polyps and colon cancer continue to have increased rate of colon cancer even after those have been removed or addressed. One of the very sad cases that I had very recently was someone who had colon cancer very early, and because she had surgery and she was cured, she assumed that she didn't have a chance of getting it again. And unfortunately, she came in with another colon cancer. And this is someone who did not have a genetically predisposition to it. But in fact, it's important that I always remind many of the people that I see that if you've had polyps in the past, particularly those who are adenomas, and if you have colon cancer, you still have to undergo more enhanced screening. In addition to that, if you have a family history of colon cancer, particularly in a first-degree relative, if a first-degree relative has colon cancer, you automatically have an increased risk for cancer. And if that first-degree relative has colon cancer under the age of 60, you definitely have a risk that means you need to have more frequent screening. One of the things that we in the GI world is that we always told people that if you have a first-degree relative with colon cancer, then you have an increased risk. But we didn't tell people that if you have a first-degree relative that has adenomatous polyps. And it just began to make sense to us in the GI world that if adenomatous polyps are the things that go on to become colon cancer, we should look at that as also a risk. So now we tell the people that we take care of, if they have a first-degree relative that has advanced adenomatous polyps, meaning polyps that were quite large, multiple polyps, or polyps of a certain histology, then they should also have enhanced screening. And then there's, of course, those people who have hereditary genetic mutations. So if you look at the slide on the left, we see how colon cancer risk increases based on your family history. So if you have no family history of colon cancer, you have one level of risk, versus if you have a family history of someone who has a polyp, the risk increases. And we are now screening those people who have a family history of advanced adenomas. We're screening them every 5 years. If you have a first-degree relative with colon cancer, you can see how the risk again increases. If you have been diagnosed with colon cancer, or you have more than one first-degree relative, you can see your colon cancer risk increases. So one of the things that I often try to talk to some of the young physicians I see at my institution is to remind them to take a very detailed family history, because that family history will also be how one determines your recommendations. There are also some specific genetic disorders, and what we have found, at least in the study at GW, is that Black Americans, or Blacks who come to our institution for healthcare, may get recommended to have screening, but their family histories are not taken as intensively as with others, and they are not often recommended for genetic testing, even though they may qualify. And so it's important that we recognize that all people of all genders and all races need to get screened via their family history, need to have their family history as part of the screening process. Our two most common hereditary disorders are familial adenomatous polyposis, and that's a circumstance we all know where someone develops hundreds and thousands of polyps in their colon, and it's almost guaranteed by the age of 40 you will have colon cancer. And then you have Lynch syndrome, which is hereditary non-polyposis colorectal cancer, where there's a significant risk for colon cancer, and we base our recognition of that risk on family history. And that's why it's so critical that 3-generation family histories are obtained. So we can't do some things about the non-modifiable risks. You can't change your age, your gender. You can't change whether you have inflammatory bowel disease. You can't change whether you've had polyps or cancer in the past. But there's some things you can change. Smoking, we know, tobacco users have a much higher rate of dying from colon cancer compared to non-smokers. People who have high fat, high red meat diets have a higher risk of having colon cancer diagnosed and a higher rate of dying from colon cancer. Excess alcohol consumption, physical inactivity, and elevated BMIs all are modifiable risk factors for colon cancer. So let's talk a little bit more detail about diet. So we know that diets that are high in fruits and vegetables have variably been reported to be protective. Studies varied, but in general, the trend in most studies suggest that diets that are high in fruits and vegetables are protective. Vegetarian diets specifically are associated with a significantly reduced risk. And vegetarians who've added seafood or pesco-vegetarians may have the most risk-reducing diet. Fiber may also be protective. The degree is uncertain. And things that are possibly protective are folate, not necessarily folic acid supplementation, but folate obtained through diet, vitamin B6, calcium, and dairy. All are look like, based on some of the studies, some of the nutrition studies, that they may be protective. We also find that people who get regular exercise may be protective. In fact, there are several studies that reported more than a 25% reduction in risk. And that exercise can be intentional exercise, aerobic exercise, or can be occupational related activity. But if someone gets regular exercise, their risk of colon cancer development is much lower. The mechanisms are not quite clear, but we know that someone who stays active has a lower cancer risk. And then there's the whole concept of aspirin and NSAIDs. Regular use has been reported to be protective to a degree, but that the rate of protection has not been enough for people to include in guidelines. And we think that the regular aspirin use, who've been studying people who are taking aspirin because of cardioprotection, have a lower rate, but because aspirin use has side effects, there's been significant reluctance to include aspirin and NSAIDs in guidelines for protecting oneself against colon cancer. But the time that aspirin and NSAID comes up is in people who have family history, hereditary disorders or genetic mutations, where they have multiple polyps, and they have not had a colectomy, or they're trying to avoid colectomy. Sometimes we will discuss using aspirin, but it still hasn't met the specific guidelines. And when you looked at the Women's Health Initiative work, you found that women in the Women's Health Initiative participants, the postmenopausal women who are on hormone replacement, have lower rates of colon cancer. But again, the associated long-term risk of hormone replacement did not warrant inclusion in colon cancer prevention recommendations. But those women who participate in the study and those women, postmenopausal women who are on estrogen replacement, seem to have a lower risk of cancer. What has been particularly exciting is some of the evolution of our screening options. Because recently there's been changes and there's been additional information and there's evolving information that we may ultimately use in our clinical practices. So we know that the most effective way to reduce colon cancer risk is regular screening, starting at age 45. No longer 50, but starting at age 45. And in those people who have significant family histories, meaning a first-degree relative who has colon cancer or first-degree relative that has had advanced adenomas, we will sometimes start their screening at age 40. And so while we all want to make sure that we maintain a good diet, maintain a good weight, and we are avoiding things that can hurt us like excess alcohol and tobacco, we know that screening really needs to be done to identify our premalignant lesions and our asymptomatic early stage cancers. And there are multiple screening options that include stool studies, radiology, newly evolving blood tests, and endoscopy. There is data which has revealed that colonoscopy and polypectomies reduce colon cancer risk and decrease mortality. A first study in the US was published in 2012 because there had been some discussion that maybe colonoscopy should not be the gold standard and we should use other modalities. But it became very clear that when colonoscopies or polypectomies are performed, the cancer rate decreased and the mortality decreased. So all our screening options, whether they're stool studies or radiology or blood tests, if they're positive, they will all lead to a colonoscopy. But there's some people who may not want to or cannot go right to a colonoscopy. So let's look at some of these screening tests. With our stool studies, we have guaiac-based fecal occult blood tests. And many of us grew up on the Hemoccult. I mean, that was one of the first tests that became available for colon cancer screening. It requires that 3 samples are done. It requires that it's done every year and identifies hemoglobin in our stool. There are dietary restrictions with the use of this particular test. We're advised to eliminate red meat for at least 3 days prior to testing and restrict vitamin C to less than 250 milligrams at least 3 days prior to testing. And the manufacturer of guaiac-based fecal occult tests asks people to avoid NSAIDs for at least 7 days. But we know that things have evolved. There's fecal immunochemical testing, or FIT tests. It's one sample performed every year, also identifies hemoglobin in the stool, and there are no dietary restrictions or medication restrictions. We generally do not ask people to stop aspirin or NSAIDs prior to doing a FIT test. And so people tend to be more compliant with getting FIT testing rather than guaiac-based testing. In the United States, we recommend it every year. In other countries, it's recommended. Some countries are recommended less frequently, but here we recommend it every year. And we all now know of the multi-target stool DNA testing with fecal immunochemical testing. And that's the one that is widely advertised, one of them that's widely advertised, called Cologuard. It's one sample every 3 years. It uses a combination of molecular assays to test for DNA mutations as well as FIT. And it turns out that the initial Cologuard, there's now a second generation that has good sensitivity. We know that if any of these are positive, we're going to move on to colonoscopy. There's also radiology. There's a CT colonography, which we also call virtual colonoscopy, and that's every 5 years. And they use thin slice CT data with enhancement to construct bowel images. They say that they can't really detect, or they're not confident to detect polyps that are less than, they say, 10 millimeters. Some people will say 5 millimeters. And why that's particularly important is because a 1 centimeter polyp, we know, has a 10% chance of already having cancer in it. So CT colonography can be used in people who are unable to undergo colonoscopy. A bowel prep is still needed. Sedation is not required, but we do know that radiation exposure is necessary because it's a CT scan. Barium enemas are no longer recommended. And then, of course, there's endoscopy. Colonoscopy is considered the standard for which everything is measured against. When you have stool tests that are done and we're looking at sensitivity and specificity, we're measuring against findings in the colonoscopy. When we have blood tests that are evolving and are being tested now, we measure it against findings in a colonoscopy. So colonoscopy is considered the gold standard. We do colonoscopies every 10 years. Preparation is required. Sedation is generally used. It is our most commonly used screening test. And the reason why people think of it as the gold standard is not just because there's a higher sensitivity and specificity rate, but we also can do biopsies and polypectomies at that time. A colonoscopy is not 100%. There are some studies that suggest that you can miss not an insignificant number of small polyps, particularly on the right side, but it's the best test that we have. A flexible sigmoidoscopy is no longer used. It was previously recommended every 5 years. Preparation was required, but as you can imagine, you're only looking at the sigmoidoscopy, the sigmoid colon. And initially, when sigmoidoscopies were part of our practices 20 and 30 years ago, it was because sigmoidoscopies inspected the part of the colon which was most affected by colon cancers. But colon cancers are no longer just occurring primarily on the left side of the colon and no longer confined just to the sigmoid. Colon cancers are distributed throughout the colon and more frequently are occurring on the right side of the colon. So sigmoidoscopies is not a recommended test. Capsule endoscopy, we all know, has been approved by the FDA for individuals with incomplete colonoscopies. It is not approved as a screening option. And very often, if one has an incomplete colonoscopy, people tend to go to CT colonography, primarily because insurance companies will pay for that with an incomplete colonoscopy. The capsule endoscopy payment is not always certain. The one thing I did want to just mention today is the whole concept of some emerging blood tests. Because some of these blood tests, we're trying to figure out how to actually fit them into our practice armamentarium. Where does it fit in the strategy for screening? So there are 2 tests we know that have been approved for detecting tumor DNA in the blood. FDA approved them just in the past few years. We're not quite sure how to fit this in. I should say that they're not necessarily reimbursed. And we're also looking at circulating tumor DNA, which means that very often we're looking at lesions that are more advanced, and certainly more advanced than one would detect from a colonoscopy. There's also another blood test that has been approved, which looks at a different type of DNA. It aids in colon detection in average risk patient who cannot or decline screening by other methods. And it's not considered adequate for primary screening right now. And then we know that there's been a test that has been looked at, a 7-gene biomarker, looking specifically at colon cancer. But this also has not been shown to detect early stage cancer. And there's, of course, some multi-cancer detection tests that have been approved, of which colon cancer is one of their target cancers. All of these, I think, are just incredibly exciting. because all of these tests, I think, will evolve and allow us to have another way that we can screen people. People sometimes don't like to test their stool, particularly since you can do it at home, and sometimes people don't like to do CT screening or colonoscopy as their first method. But these tests right now, although quite good and evolving, are not great for polyps and are not good for polyps that have not become advanced polyps and may only be sensitive enough for cancers. And so they're emerging, they're evolving, and I think it's an exciting time for these to develop further. And so I wanted to mention it because there's now been approval for many of these tests, and we are going to see more of them in our practice. So when we look at screening, screening is low across the nation. It's low, and it's too low for anybody in the country. We find that there are certain populations in which their screening is less than the overall general population. So for instance, when you look at the general population of whites in this country, there's over 60% screening. But when you look at Black Americans, you find that the screening is less than 60%. Neither of these are acceptable. And when you look at colon cancer mortality, you find that the colon cancer mortality is decreasing, and it is significantly decreasing because there's been more screening. Mortality remains highest among people who get screened less, but the decrease in mortality, as we look at all the potential factors that are involved in making that decrease occur, is because screening is something that we remind people to do and that we should continue to remind people to do. The earlier colon cancer is found, the more likely there is survival. So in early colon cancer, we have 90 or more than a 90% survival rate. It declines as we get more advanced disease. And when we get distant disease or metastatic distant disease, we find the screening rate may be as low as 13%. So the overall survival for colon cancer is 65% at 5 years and 58% at 10 years. But the earlier you get it, the more likelihood one is going to survive. So that's why screening is absolutely critical. Studies have found that Blacks are less likely to undergo screening, but even when colon cancer is found, may be less likely to receive appropriate surgery, maybe appropriate chemotherapy, or even radiation treatments that have been recommended by others. 9 out of 10 people can be cured if it's found early. But once it's found, we want to make sure that everybody gets appropriate treatment. When they did a study at the VA, they found that when things were protocolized, when there is a specific protocol on how one gets treated and how one is treated with a particular disease, you find that Black patients did just as well as everybody else. So that really made us understand that outside of an institution where things aren't on a protocol, that sometimes some people may get variants of standard therapy. Survival rate differences disappear when cancer treatment is comparable. But the one thing we do know for all conditions is that patients who are privately insured are more likely to survive any condition than patients who are uninsured. And that certainly maintains true for our Black patients and our Black population, our Black community. So Blacks have a higher morbidity and mortality, we know that. We have a higher rate of colon cancer. We're diagnosed under the age of 50 more than any other ethnic group. We undergo less screening than other ethnic groups. We less often receive recommended treatment unless there is a specific protocol at an institution, and we have higher mortality rates. But we can make a difference. we can improve cancer outcomes by increasing awareness in colon cancer, by improving screening, by trying to decrease those barriers, by making sure that treatment is the same across the board, by participation in clinical trials if appropriate, and by partnering with a healthcare provider. I can assure you that if we do these things it can make a difference. We can increase our screening rate if we address the specific barriers. Here in Washington D.C., not only did we increase our screening at our institution to well over 70%, we did it because we addressed the multiple factors that are involved in allowing people not to get screened as regularly as we would like. Not only having reminders in their charts or outreach by our institution, but by having navigators, uh, nurse navigators to allow people to go through the institution seamlessly. We also have done incredible and significant outreach in our community. But it's not just the community that needs to have outreach and understanding, it's also our physicians. Because one of the things that we learned is that people who come in for care may not always get the care that they come in for. And so we educated our residents, our students, our faculty, our community, and we addressed many of the barriers that exist. So I have a number of references here in case anybody is interested. And I really appreciate the opportunity to be here today.
Dr. Borum, first I want to thank you so much for this extremely informative lecture. And I wish I were a medical student again so I could come through your course. But let me ask you two questions. Can you speculate on why the death rate is increasing among younger people from colon cancer? And what is the relationship more directly of diet to microbiome?
Yes, one of the things that became important over the past few years is the recognition that colon cancer is occurring in younger and younger adults. At first, it wasn't something that was necessarily recognized because the overall death rate in the United States was decreasing. But once they looked at it based on age groups, they found that younger adults were getting cancer more frequently. And then one of the things that they speculated initially was that maybe the cancer was a different type of cancer. And maybe that different type of cancer was what resulted in younger adults dying. But when you look at the cancers in young adults, they're the same cancers as in older adults. It's the same molecularly, the markers are the same, the type of cancers are the same. So it's not that younger adults have a different type of cancer. So that then led people to begin to think about what other factors are allowing for these cancer rates to increase, particularly in the younger population. And one of the areas that has gotten more attention has been the area of environmental exposures and diet. And we find that we can't ignore the fact that there are things that surround us and the things that we take in that impact whether one has an increased cancer risks. And I think that is indeed true in colon cancer also. We think diet has a significant impact upon colon cancer development. And we really try to ask people to moderate their processed foods, their red meat, their high fat, uh, their high fat that can occur in their diet. But as we talk about diet, what has then happened, and the next step has happened, which is apropos to your question, is because what we take in affects our intestinal environment. And so the question is that we move into is the whole concept of potentially having microbiome alterations within particularly our colon that allows for certain types of carcinogenic activity to occur. There is so much work that needs to be done on that. We have a circumstance where we do not have specifics about how the microbiome may impact colon cancer development specifically, but we do know that there are different microbiomes in different people. Individually, we all have our own fingerprint, our own colon print. And so we are trying to investigate that as we're looking not only in colon health, but also as we look at colon disease. So there are some very active researchers and some institutions that are looking at microbiome specifically and all sorts of issues. We are beginning to try to develop some studies here looking at microbiome in the gut. And we think that we are speculating that that has to have an impact, that may have an impact, at least in some people. And that has to do with our diet. And so I so appreciate you bringing up that question because I think that dietary factors are underrated when it looks at how that affects the intestinal health. But in fact, we know for certain that diet impacts our risk for colon cancer.
Thank you so much. My favorite pediatrician, Dr. Barbara Stevens.
Thank you, Dr. Maxey. So this is a truly devastating disease if it is caught late. And it's also preventable if you do the screening. What is the barrier? We've talked about the socioeconomic, we've talked about dietary, we've talked about the evolving knowledge of the biome and the function of the biome in the whole scheme of things. But if you were at a family gathering, not necessarily your family, but if you were at a family gathering, what would be the most effective way to communicate what they need to be doing?
You know, I face this not infrequently, right? Because you're suggesting that people may want to change their lifestyle and change their dietary habits. And so one of the ways that we often try to approach it with my friends, family, and community is to talk about let's just start in moderation. I'm not asking you to completely give up your meat and your processed foods and and barbecued foods and things that allow for some of the things to be carcinogenic. I'd like you to, but let's just do it in moderation. Because if you ask people to stop smoking, stop drinking, and don't eat meat and don't barbecue in the summer, then that becomes not a message that is readily received. So I ask people at least to begin in moderation. And a little bit helps a lot. And I
Man,
think that is indeed a barrier that we want to cross, we want to face, and we want to face a lot of barriers that have not always been identified. Not
man,
only is, I'm sorry.
I'm saying, but may I just ask you, what is it about barbecue that helps cause more cancer? The
We
compound.
think that we think that it's the high heat that people use to grill their meat that results in increased activity within the intestinal lumen and the microbiome. So we think that it's that high heat in barbecue that does it. Sort of, I think of it similarly to some of the patterns that we have when we look at gastric cancer and certain processing of certain foods. But we know that those barbecued foods and the high grill, we'd like to limit it a little bit. We'd like to moderate what we take in, and we'd like to avoid having a lot of red meat.
Thank you. Dr. Walks, how are you, sir?
Everything's good, Dr. Maxey. I have not had any barbecue today yet. Dr. Borum, thank you again for coming through and really allowing us to learn a lot. I have a couple of questions. One maybe very simple, and the other one not so much. A lot of marketing is done for probiotics. If you take this probiotic or that probiotic, that's going to just fix everything. So if you can make a couple of comments about probiotics, that would be helpful. And then maybe a little bit less, I don't know, question. Another question would be I know that a lot of my patients are impacted by what's happening with their mental health and how it impacts their gut, how I get all stressed out and now my IBS is acting up, or if I don't, manage the stressors in my life, my Crohn's is worse. And so there are a lot of psychiatric and psychological challenges that relate directly to how we pass things through our gut. So probiotics, good, bad, neutral, and what about the mental health aspects of the whole GI issues?
Probiotics is an interesting topic, particularly for a gastroenterologist, right? Because we talk about probiotics in the context of changing the bacterial environment within our colon. And the initial studies for probiotics, at least in the GI world, was around inflammatory bowel disease. And with that probiotics and inflammatory bowel disease, we find that some probiotic preparations helped with very specific instances in IBD. And that specific instance tended to be around the concept of people who've had ulcerative colitis, have had their colon out, and now have a surgical pouch that is made by connecting the small intestine to the rectal area and have a pouch. So people who have pouchitis will benefit very often from probiotic work. That then moved toward looking at probiotics or certain supplements in relation to ulcerative colitis in general. And there's some people who will use that in the context of adjunctive therapy for their IBD. And so you can imagine people then began to extrapolate that perhaps probiotics, since they're making IBD, certain circumstances of IBD better, that maybe this is an area in which we can get good intestinal health in general. We don't have good studies for that. It turns out that, for instance, even when we looked at inflammatory bowel disease, there was only one probiotic preparation that was studied. And all the other probiotic manufacturers tried to make it so that their combination of bacteria looked similar to the only one that has been studied. And those other probiotics have not been at least rigorously studied in the GI allopathic world. So when it comes to maintaining good health, we know that much of the time it doesn't hurt. We are very careful and are very specific about people who are, for instance, on immunosuppressants for a medical condition or immunosuppressant in general. We may not use certain kinds of supplements in that arena. But we don't know that probiotics specifically can help with certain disease entities or in decreasing the risk for colon cancer. I say that knowing that for some people, taking probiotics makes them feel better. And if it doesn't hurt, then it's okay if it makes you feel better, as long as it's not hurting you. But that goes back to Dr. Maxey's question. about learning more about the microbiome, because there may indeed come a time when we learn that there are, in fact, certain probiotics that make sense for us to take in certain circumstances. We also know that there's anecdotal evidence, not well studied, but there's anecdotal evidence that people, for instance, who have been on antibiotics or have been traveling, we will often they will often reconstitute their gut by taking prebiotics or probiotics because their gut microbiome may have changed because of an intestinal infection or because they've traveled to other parts of the world. We don't have good studies on that. All of this is speculative, but there's enough anecdotal experience for us to know that more study needs to be done.
Thank you so much. Any of our other
We
co-moderators?
didn't, we didn't get to the mental health piece yet. Dr. Maxey, hold on. She was just taking a breath.
Okay.
So the issue is about mental health and the gut, and that is an area that all of us have seen has evolved over the course of time and over the course of decades. Because I remember when I first went into gastroenterology, you would have circumstances where people will come in and discuss certain GI concerns and have certain GI symptoms, but you'll find all of their labs, x-rays, testing was normal. And so then I would get this hushed phone call and consult about saying, oh, we have someone, everything's normal, Dr. Borum. And, I'm thinking that maybe it's a mental health issue. When in fact, many of us know that it is not. It's not. The symptoms that people were feeling in their gut were not necessarily a mental health issue. And in fact, there was a gentleman here in the Baltimore area, I should say, who used to be a psychiatrist, who went back and became an internist and gastroenterologist. He's no longer with us. He was generations ahead of those of us on this call. But what he speculated was that people who were coming in with these symptoms did not have a psychiatric disorder. They had a motility disorder, and he became one of our motility experts. One of the things that he did was to do some investigational work where he made like an EKG of the gut. He had electrodes made in the gut. He watched how the gut moved. Where he was correct is that many times people who had these symptoms actually had differences in the way their gut moved. But the patterns were all different. He thought that maybe there may be a certain pattern to that irregular movement, but the patterns were all different. And so what we found that people can certainly have changes in the way their gut moves to give them symptoms, and they have a visceral hypersensitivity. They're more sensitive to what goes on in their gut. We do have an overlap of people who have visceral hypersensitivity and irregular gut movement. We do have an overlap with sometimes people who have depression or anxiety. They may have these symptoms, but that doesn't mean that their gut is related to the fact it's not generated because of a mental health issue. It's generated because there's a motility issue. And you can also imagine that people who have inflammatory bowel disease, who already have a special kind of gut, a special kind of environment, can also have a special kind of movement that can be impacted on the way our gut moves. And we know our brain gut phenomenon from the researcher at Columbia University a couple generations ago knows that that connection is quite real. So mental health impacts upon the way the gut moves, but the gut already has a movement to it that allows for it to have symptoms and a visceral hypersensitivity that allows us to feel it.
Thank you so much.
Okay. Are any of our other co-moderators on?
No, but Dr. Holder has her hand up, Dr. Maxey.
Dr. Holder, please speak.
We have to get the mute off for Dr. Holder. And then Dr. Lawson also has his hand up.
Okay,
And Dr. Sherrod.
okay, let's go in that order.
We
Dr.
still
Holder.
have Dr. Holder on mute, and she's not able to unmute.
Okay, Dr. Lawson.
He
Dr.
too
Lawson
is
is
on mute.
Dr. Lawson is also in the unmute category. Uh, calling out to Simon for some help.
In the meantime, let me ask you, Dr. Borb, and this is sort of funny, but who is Montezuma and Montezuma's Revenge?
Yeah, you tell me.
When you go to Mexico and come back and can't get out the bathroom. Dave,
There-
get unmuted?
Not
Dr.
yet. Not
Try
yet, Dr.
unmuting. Dr. Holder, try unmuting on your side. It's not working.
Let me try to call. I don't know. What's going on here?
Dr. Max is trying to get to the bottom of it. In the meantime, Dr. Neighbor Stevens, can you work on your lip reading skills?
Well, I can read you Dr. Sherrod's question in the meantime. She wants to know, what is the relationship of SIBO to colon cancer?
SIBO, small bacterial intestinal overgrowth. We do not know there to be a direct relationship with that and colon cancer. We know that SIBO is the result of having bacteria that has snuck into the small bowel, lives there where it takes up home where it isn't supposed to be, and then results in symptoms related to this bacteria that's multiplying in our small bowel. We do not know that to be related to colon cancer.
Dr. Holder?
And Dr. Holder wants to know about the relationship of vitamin D and colon cancer.
Yes, that was not on my
I'm
slide.
sorry, and any other particular vegetable with more protective effects.
The ones that that I listed are the ones that they actually have good data about. The one thing that I didn't list, and I thank you very much, Dr. Holder, is the issue of vitamin D, because that's one of the newer deficiencies that has been identified to potentially be related to colon cancer risk. So we have people who we know that if we supplement with folate through our diet, that's helpful. We know maintaining vitamin B6, having adequate, that is helpful. And we know that calcium in dairy, which is some of the things I worked on many, many years ago, are potentially helpful. And now we know that vitamin D, having adequate vitamin D, not necessarily high vitamin D, but certainly within the normal range that we know it to be, seems to be something that is protective. Even if it's not protective or decreases our risk, we know that having adequate vitamin D in our diet does not allow us to have increased colon cancer in individuals.
Holder, are you able to unmute as yet? Oh,
I'm unmuted.
Now I can. Okay. Thank you. I wanted to follow up. Do we have enough evidence at this point that we just tell Black folks? So I tell you, every patient is low that I've ever checked, and I'm in the South. So
In the sun.
the sun. I can imagine in the North and everywhere else that doesn't have as much sun that it's just as low. Just to take replacement.
Right.
Point for Black folks.
What I have seen is the increasing pattern among some of our primary care providers is to ask people to consider taking vitamin D supplements, about 2,000 units a day. I know that one of the things I do, because we don't have specific recommendations, is I check, particularly if they're coming in with GI, and you can find a reason to check, right? You can check it because if someone's on prolonged PPIs, you can check it if they have IBD, you can check it if they have polyps. For reasons that I'm going to see someone regularly, I will check a vitamin D in certain circumstances and supplement them. And because I think that it's important, because vitamin D is not just for colon health, we know that vitamin D impacts so many other areas of health.
Yeah, just to follow up in the South, we have such a high rate of uninsured population. So even when I do see them, they don't have enough insurance to pay for any lab tests. So that's why I was hoping at some point folks just say do it. It's cheaper than trying to see the doctor to get these.
Right, right, right. And over the counter, 1,000, 2,000 units a day is
It's,
something that,
yeah. Thank you.
Thank you. Dr. Lawson unmuted yet?
Dr. Lawson, are you able to unmute? Not yet. Dr. Sherrod is unmuted though.
Okay, Dr. Sherrod.
Yeah, good afternoon, and thank you, Dr. Borum, for such an outstanding lecture. I came on late, and I apologize for that, and I don't know what the real topic is. Is just colon cancer? Because I wanted to ask you a little bit more about SIBO, the small intestinal bacterial overgrowth. Is that not the topic today, or?
No.
no, it's not, but it's one of my favorite topics because I
Oh,
see it every
fantastic.
day. It turns out that the topic was about colon cancer prevention and screening, but in fact, SIBO is increasingly recognized as an issue in many people. We find that there are so many people who have come to me because they have been diagnosed with irritable bowel syndrome, when in fact they had SIBO and they had SIBO-related bloating and discomfort. So we know that small intestinal bacterial overgrowth is something that has been under-recognized in many circumstances, and in fact can give significant amount of GI symptoms. And now we have tests that can be done that are covered by insurance in your labs, or home tests that can be done. You can have insurances will pay for some home tests that people can just get it done at home. And in fact, SIBO, we know, can result in significant GI symptoms that are persistent. There are certain people who are more predisposed to SIBO, as you can imagine, people who have certain collagen vascular diseases and dysmotility in their gut. They just don't have the migrating motor complex in their small bowel. That is our housekeeping movement that allows things to sweep through the small intestine and clean it out. And so SIBO can result there. People who have strictures in their colon, in their small bowel, may not have the sweeping movement through the small bowel to allow for bacteria to get cleaned and go into the colon. We also know that people who have diverticula in their small bowel do not have do not have complete cleansing of the bacteria from their small bowel. So there are lots of reasons people can have that. And in fact, I think that's an area that deserves lots of discussion. But the one thing we do not know, and we have not identified as SIBO as being something that is related to either small bowel or large bowel malignancy. So that part is good.
Thank you so much. Is Dr. Lawson unmuted yet?
Dr. Lawson is unmuted.
Yeah, I just want to quick note that Dr. Borum is the editor of our distinguished journal, she's editor-in-chief of the Journal of the National Medical Association, which in itself is a very interesting history in terms of providing a place where it couldn't get relevant articles in terms of our folks in other places, which has become one of the more highly ranked journals in recent years.
Dr. Lawson, before you came on, I proposed a relationship between Dr. Borum's research and yours on the relationship between the microbiome and mental health.
I'll go even further than that. I did a study a couple of years ago in which we had a patient that had active bipolar disorder, a frank manic episode that led to his hospitalization and usual treatments. But we also found out that he had a mass in his colon. When we removed the colon, all of the symptoms disappeared. And that's been reported in several other places. We now know that some of the, I guess Dr. Borum will say more about this, but some of these cancers can produce neuroactive agents that in turn can affect the brain. Plus, I would like to add that there's, of course, a widely used treatment for treating resistant depression, in which we actually use the stimulation of the vagus nerve to be able to reduce it. And we now a lot of us talk about the brain, the brain in the belly in terms of its relationship to the brain in the head.
Yeah, I know. And some of that work that came out of Gershon at Columbia, and I know this is really off topic, but I know that Gershon happened to be a gastroenterologist that liked to be in the lab
That's right.
rather than in the clinic.
Right.
And his area was the area of serotonin that Dr. Lawson well knows. And one of the things that he was able to identify for many of us is that most of the serotonin actually lives in the gut and not in the head. There's certainly different subtypes, but we can imagine that there is potentially significant overlap. And so he was one of the first gastroenterologists that led us to understand about that relationship between the brain and the gut.
Well, thank you so much. We're at the top of the hour. I'm going to ask for conclusion comments by Dr. Borum, and then our co-moderator.
Oh, I just want to thank everyone, and I want to thank you for inviting me to speak today on a topic that's something that I have been studying and looking at for many years, in particular colon cancer screening. And I so appreciate the attention that we're giving to it because we know that this is causes significant morbidity and mortality in the United States. We know that it affects more populations more than others. We know that screening, this is one of the malignancies where screening can actually get and take out precancerous lesions. We know the stepwise from precancerous lesions to malignancy, and we can actually impact that with doing our screening. And we have to make sure that we talk to our friends, our family, our community to get that done, and make sure that we connect people where they need to be connected to get the kind of treatment that they deserve. And so I so appreciate you inviting me, and I hope to come back again soon.
Well, thank you. I got one more question. I'm a natural medical chicken. I'm afraid of dentists, afraid of doctors, and any procedures. Can you tell us why it's so easy to have a colonoscopy, why it's not threatening? Just quickly tell us why we can all do it without any fear.
The worst part about getting a colonoscopy is preparing for it, and that one does at home. The actual procedure one sleeps through and is not painful, and you don't remember it. I think that very often it's the first procedure that is difficult for people. Once they realize that having the colonoscopy is not as hard as preparing for it, then they're not as reluctant. We actually did a recent study that tried to figure out some of the fear barrier, and we found that fear in men versus women had a different impact upon their adherence to colon cancer recommendations, and fear in young adults versus older adults also impacted when and how they got screened differently. So I think that if we can just get people to the first colonoscopy, then we're good with the subsequent ones. But even a gastroenterologist recognizes that the best screening test is the one that's done. So if it's stool test, that's fine. If it's radiology test, that's fine. It doesn't matter to me. And the upcoming blood tests that are not yet prime time for screening, but maybe they're soon, that's fine. It doesn't matter to me how you get screened because those positives ultimately, if someone has a positive screening, then they know that they should get a colonoscopy. That's not just a question. So the best screening test is the one that's completed, and I advocate for all of them.
Well, thank you so much. Dr. Ivan Walks.
Thank you, Dr. Maxey. Dr. Borum, again, thank you for your just the way you shared your information. And I wanted to focus on the fact that I was very excited about your showing all of the different folks that have been prominent in many, many different areas that have had their lives cut short or impacted by colon cancer. So many times we try to give people health information and you've got to find a way to relate it to them so that they actually will not just hear it, but they will actually use it. And I think that that strategy of saying, you know, so and so and so and so and so and so, no matter where your background or wherever you think the indestructible people live, and if you think you live there, I think that kind of an approach can be very useful. So thank you for that.
Thank you.
Thank you.
Dr. Barbara Neighbor-Stevens.
Thank you, Dr. Borum. It was so enlightening, your talk today. And I certainly echo Dr. Walk's sentiments because I have personal family history of colon cancer, so it's a subject that's very close to my heart. But when Chadwick Boseman died, I was just devastated. And I would suspect I'm not the only one that was so impacted by his untimely demise. And so, yes, you have taught us in how to communicate, and you have taught us in what to communicate. And I can't wait till you come back again. Thank you.
Thank you.
Finally, thank you so much. We're very honored by your presence, Dr. Borum. And everybody have a great afternoon. Thank you, Simon, for helping us with this. Have a great day. Enjoy your day.
Good day, everyone.
Bye.
Bye-bye.